Regina Spicer for the ADAMHS board, and I'm going to turn it over to Jean right now so that she can tell you a little bit about, do her introduction about the Hoarding conference and the expectations. So Jean, I'm going to turn it over to you.
Okay. Hi, I'm Jean Hoban. I'm from Benjamin Rose Institute on Aging and the Hoarding Connection of Cuyahoga County. And thank you for joining us for Hoarding 101, or as Bert is calling it, Hoarding Behaviors, Identification, and Management. This is the first session of our three-part conference series, Perspectives on Hoarding, that are being presented by the Hoarding Connection. The conference series is presented with funding from the ADAMHS Board of Cuyahoga County, with support from Benjamin Rose Institute on Aging. Today's presentation is being recorded, and we will be sharing a link with everyone who attends today following the program. Also following today's session, you will receive an email with a link to an evaluation form. If you're applying for continuing education credit, you are required to complete that evaluation. Others in attendance are welcome to provide feedback as well to help us improve future programs. There's a lot of material to cover today, so we will be holding questions until the end. However, you may enter questions at any time during the presentation using the chat box at the bottom of your screen. And Regina, do you have any other additional housekeeping items you need to share?
Absolutely. Thank you, Jean. Again, I'm Regina Spicer. This is a large presentation, so we are going to ask that everyone stays muted, but you, again, can use the chat box to make comments or ask questions, and we will get the attention of the speaker at that appropriate time so that the speaker can answer your questions. If not, he'll hold a Q&A session toward the end of the presentation, and you're welcome to stay on and conversate with him at that time. As for the ADAMHS board, we are will be giving you your CEUs and RCHs. So in that respect, if you are in need of CEUs or RCHs during your registration, you should have provided us with your license number. The CEUs and RCHs, for those of you who hold an Ohio license, we will be able to put your CEU information into CE Broker. Those of you who are out of state, we will email you your certificate so that you can give it to your prospective boards in that state. Following this training, you will be sent a link via SurveyMonkey to complete the survey. Please complete the survey in a timely manner, because upon receipt of the survey data, only then will your certificates with the CEUs be sent out. As we said, this is a large audience, so we will be taking attendance upon entry. If Bert or Jean decides to give a break, we'll take attendance after the break. And once Bert concludes his presentation, please do not exit until we can tally the attendance following the presentation. You are expected to stay for the whole 2 hours. However, if you do leave or have to leave for whatever reason, we will credit you the CEUs for the time spent and the training. So without further ado, we know that that your time is important, as well as our presenters. So I'm going to turn it over to Jean so that she can introduce the facilitator. Thank you.
Okay, thanks, Regina. Our speaker today, Norbert S. Rahl, LASWS, is the retired director of the mental health program at Benjamin Rose Institute on Aging, where he worked for 43 years. Bert has extensive clinical experience working with clients with mental illness in both individual and group settings, using evidence-based practices such as cognitive behavioral therapy and illness management recovery. He has worked with individuals with severe mental illness, such as schizophrenia, bipolar disorder, psychotic disorders, personality disorders, and of course, hoarding disorder. Bert has served on the ADAMHS Board Suicide Prevention Task Force, was a former president of the Council of Agency Directors, and served on several committees of the Mental Health Addiction and Advocacy Coalition. He has also been an adjunct faculty member at Case Western Reserve University. He continues to serve on the Cuyahoga County Adult Protective Services Steering Committee, regularly attends APS collaborative meetings, and remains active on the Hoarding Connection. Bert is currently president of the Board of Trustees of the Supplemental Care Services Association, a pooled Medicaid trust for individuals over 65 years of age. He is also a member of the Council of Older Persons here in Cuyahoga County, better known as COOP. And now I will turn it over to Bert for Hoarding 101. Bert?
Oh, thank you, and welcome to everyone. This is a basic presentation. So for people who are somewhat familiar with clients who suffer from hoarding disorder, you'll have to bear with us, but it's also designed to bring people up to date on hoarding disorder for those who have no experience with it. So let me first give an explanation about the Hoarding Connection of Cuyahoga County. The Hoarding Connection started in about 2008. The basis for it came from the ADAMHS Board of Cuyahoga County in 2004 applied for a large SAMHSA grant that was designed to help seniors in crisis. And it consisted of 7 agencies, the ADAMHS Board, Benjamin Rose Institute on Aging, Recovery Resources of Cleveland, the Adult Guardianship Program of Cleveland, the Department of Senior and Adult Services, APS, Adult Protective Services, Frontline Services, and the Margaret Blankner Research Division of Benjamin Rose. So let me give a little background about Benjamin Rose. It was started in 1908 by Mr. Rose. He was a wealthy Cleveland financier, and part of what happened is he saw a lot of his male friends die and leave their fortunes to the wives, who often had little experience in managing finances, and they ended up losing their fortunes and becoming destitute. So when he passed away, he left his entire fortune and dedicated it in a trust to provide for the elderly. So Benjamin Rose was started in 1908 and continues to this day. They do advocacy services and research. When the SAMHSA grant started in 2004, or actually it started in 2005, over the course of 3 years, which is what it ran, Benjamin Rose admitted over 120 individuals who were identified as being in crisis and were referred to Benjamin Rose. The plan was that they'd be seen by 2 workers from Adult Protective Services and a worker from Mental Health Services to determine what their needs were, and then they'd either be referred to Recovery Resources if they had an addiction problem, or Benjamin Rose if they were in crisis, but not because of addiction. So out of the 120 people that were referred to Benjamin Rose, a high percentage of them were suffering from hoarding disorder. Because of that, we formed a task force, which we call the Hoarding Connection of Cuyahoga County, dedicated to working with people who suffer from hoarding disorder. So there clearly were a lot of people with hoarding disorder, enough to bring them to our attention. So objectives for today, we're going to look at hoarding disorder, incidence and prevalence, types of hoarding disorder, and how to manage it. Towards the end of the presentation, we'll get into management a great deal more. There are basically two types of management. One is management, that is, how do you deal with a hoarding situation? And the other one is treatment, trying to help people overcome hoarding disorder. So hoarding disorder is a psychiatric illness. Clearly, people have a problem with getting rid of things, developing excessive accumulation, and it affects most areas of their ability to function. So it's really a three-part problem. It's a problem of collecting too many items. It's a problem of having difficulty getting rid of them. And it's a problem with organization. And one of the keys, particularly for the diagnosis, is that it has to affect function. It poses safety and health risks and results in significant distress or impairment in day-to-day living. When there's no impairment, there clearly can't be a hoarding diagnosis. So a little bit about the history of hoarding disorder. It was originally called the Diogenes syndrome. Diogenes was a Greek philosopher, and it was really a misnomer. He was actually a minimalist and a cynic. He was anti-government. He was known for collecting and going through garbage and discard, but he didn't keep it. So it's been around since known history. We've had people who suffer from this problem. The first written description was in Dante's Inferno from the Middle Ages, where he talked about people rolling these enormous weights back and forth. And the dichotomy of why do you hoard and why do you waste? Because hoarding disorder is clearly, people hoard to keep things, yet because they don't use them, they end up wasting them. So there's always been that problem with hoarding disorder. So it's clearly now a diagnosis. When the DSM-5 came out in 2008, it got its own category. Prior to this, it was listed in the DSM-4, which came out in 1994. It was its first printing. It was listed as a subcategory of obsessive compulsive disorder. For anyone who's worked with hoarding clients, they know that they generally do not look like people with obsessive compulsive disorder. Now, doesn't preclude people from having both obsessive compulsive disorder and hoarding disorder, but it really is not a subcategory of it. In the original DSM-4, it was considered a subcategory of it. So what it starts with is persistent difficulty in parting or getting rid of possessions. And excuse me a second. And those possessions build up, and it has nothing to do with their actual value. I'll talk about that more in detail in a few slides. And the difficulty is due to a perceived need to save the items and distress associated with discarding them. The symptoms result in accumulation. The accumulation not only affects their living areas, but for many of these people, it interferes with their work environment as well. People that work in offices and handle paper in particular can fall victim to being fired because of the way they keep their workspace. So let me go to the next slide. It has to include clinically significant distress or impairment in social, occupational, or other important areas of their life. So over the time that I worked at Benjamin Rose, let me go back and talk a little bit about some things that were unique about Benjamin Rose. Besides being dedicated to the elderly, one of the things that made Benjamin Rose unique was all home visits. It was pretty rare. We did some group work in the offices, but very minimal. Almost all of our work was done in clients' homes. So for the bulk of my time at Benjamin Rose, I was out in the field visiting people in their homes. Originally, we covered not only Cuyahoga County, but had some clients in adjoining counties. So I got to see a lot of people's homes, and clearly a lot of hoarded homes as well. The hoarding does often not have immediate distress on the individual. And we'll get into that in the next slide, but in particular, people who hoard generally are quite comfortable in their hoard. When they're inside with all their possessions, they feel no distress. Sometimes they feel distress, and the distress usually comes in two areas. One is that they're trying to find something in specific that they're looking for, because usually they can't find it. And the other thing that happens is if somebody knocks on their door for a brief period of time, they'll be able to see the conditions they live in through the eyes of the person who's there. And then usually it passes pretty quickly. So the distress may or may not be present or evident when you're seeing a person, but there's always some level of distress. The DSM-5 makes it clear that you also have to make sure that the hoarding disorder is not a function of some other kind of underlying condition. Many people with major depression will lose their energy and motivation, and so they can begin to accumulate a lot of material objects in and around their immediate environment. So you want to make sure that it's not depression. A problem like Prader-Willi syndrome. For those of you who are not familiar with Prader-Willi, it's a genetic disturbance. It involves food. People begin to, they have the inability to recognize satiation. So they become obsessed with food and will accumulate large amounts, often perishable products. So they will, their environment will look like a hoarding situation, but the difference is it'll all be about food. Generally, these people are massively obese or overweight, but it's not hoarding disorder. Prader-Willi can be determined by a genetic test to identify the gene that it involves, and so they can be ruled out in that fashion. You have to make sure that the comorbid symptoms of other illnesses aren't responsible for it. So people with obsessive compulsive disorder who accumulate a lot of things, you need to do a good assessment and make sure that the problem is not because of a comorbid problem and not the hoarding disorder. Um, so there's a couple of specifiers when you're looking at the diagnosis of hoarding disorder. One is insight, good or fair insight, poor insight, and absent insight. Absent insight are people that have delusional beliefs. Their connection with reality is often tenuous. And so they'll, these people will likely end up being homeless. I've met a couple of these people. Fortunately, there are only a minor percent of them. Most hoarding disorder clients have some level of insight. The ones with absent insight are really a problem. One client I had was living in subsidized housing. He had a tremendous amount of goods, particularly clothing. He was referred to us by a legal aid attorney. She had somehow developed a pretty significant relationship with him. He really looked up to her and was willing to accept our help based on her recommendation. When she was involved, we made a lot of progress. We helped him get a couple of storage lockers. She arranged to help some movers, and we moved most of his stuff into the storage lockers. The place actually got pretty clean and acceptable. And then unfortunately, she got transferred to a different city and moved away. He was still willing to see me, but without her influence in his life, it didn't take long for him to end up reaccumulating even more goods, and then got evicted from his place and ended up homeless. So insight is very important, and this correlates to how well treatment goes. The best outcome clearly is for people with good or fair insight to get some treatment and to make progress. Those with poor insight or absent insight aren't going to be so lucky. So a couple of terms of note. The first is anosognosia. And anosognosia basically just means lack of awareness. And this is pretty clear from people with hoarding disorder. On one hand, they're generally able to articulate that they don't look or live like other people, but they don't know what to do about it, and they don't recognize this as a problem. The fact that their living areas often have so much accumulation that there's only narrow pathways to walk through, it's just lost on them. It just doesn't bother them at all. The second term of note there is sologomania. It's from the Greek language. It's what we would commonly refer to as squalor. So I would note quickly that not all people suffering from hoarding disorder have sologomania. And many people who don't suffer from hoarding disorder do suffer from sologomania. These are people that just have different cleanliness standards than us. I treated one young lady. She was an animal hoarder. She had at one point in time, she told me she had about 18 cats. When the situation imploded and they actually did, the animal control did a clean out of her house, they actually found 30 some cats. Many were living in the rafters of her basement. She did not have her animals spayed, so they'd often go into the basement, have multiple litters, and the cats were wild and feral and just hid down there. She had a small bungalow in an inner ring suburb of Cleveland. So when I'd go over to see her, I'd go in the side door, and there were 2 steps up into her kitchen. She held a linoleum floor. And even though she picked up after the cats, she'd often only do so with a paper towel and pick the solid matter up and dispose of it in the toilet. So when you'd look across this linoleum floor, all you could see were chunks and pieces of fecal matter from the cats. So that, the place was actually filthy. I never saw her wear shoes inside the house. Indeed, once towards just before it imploded and she got taken out of her house, she ended up getting a cut on her foot. It became infected and she was hospitalized with sepsis, almost died from it. So Sologomania is not common in hoarding disorder, but when it's present, they're basically your worst case scenarios. Very hard to deal with. So incidence and prevalence. How often does it occur and how widespread is it? This slide, I took the information from the National Institute of Mental Health in 2007. Now, since that time, the National Institute of Mental Health has changed its website a lot, and you no longer can find it easy to find this kind of information. But I keep the slide because of the percentages, and to show basically where hoarding disorder falls in the range of mental illness. So, the top rated mental illness is anxiety disorders, 20%, that's 1 in 5 people. All the way down to schizophrenia, 1 to 2%. So hoarding disorder, the estimates range between 2 and 4%. Dr. Samuels, in the references you'll find, did a pretty thorough study and found that roughly 5% of people were suffering from hoarding disorder. The other reference there is from the San Francisco Hoarding Task Force. They published a study that took them 3 years to do. It's called Beyond Overwhelmed. It's still up on the internet. If you Google Beyond Overwhelmed, it'll bring it up. It's about 100 pages, so it's not something you want to print off. But they did a pretty comprehensive study of hoarding disorder in San Francisco. San Francisco is kind of unique because the way the county, Marin County, includes the whole landmass of San Francisco surrounded by water. It gives them a chance to collect lots of useful information. I know it varies from state to state about how people collect mental health information. In the state of California, mental health information is collected by the state, and the services are provided by the state as well. Whereas in other places, particularly Ohio here, the state doesn't do services. They contract them out to private providers. What that gave San Francisco the ability to do was to gather information from multiple providers. That allowed them to accumulate cost factors, such as police interventions, ambulance interventions, healthcare workers and stuff. And they found that the annual cost, and this was in 2008, the annual cost to Marin County was over $2 million. So hoarding disorder not only interferes with the individual, it costs you and me as taxpayers quite a bit to deal with. So the primary researchers who are responsible for what we know about hoarding disorder are listed here. Dr. Randy Frost and Dr. Gail Steketee did some of the earliest research on it. The hoarding connection of Cuyahoga County has had Dr. Frost present several times. He indicated his first study was done in 1992. He thought it was going to be a flash in the pan, meaning that they were going to do one quick study on it, and that would be the end of it. So the study he did in 1992, when the results came back, they were so fascinated with it, it led to more and more studies. And then he eventually developed a treatment theory, which he first published in 2007. Dr. David Tolan, who we've also had come as a speaker to do seminars in Cuyahoga County, is an assistant professor of psychology at Yale and does a lot of treatment. Dr. Sanjaya Saxena is a psychiatrist at the University of San Diego, or California at San Diego. And all of these people have done and presented a fair amount of research on hoarding disorder and have really gotten us to where we are today in terms of how, what we know about hoarding disorder and how to treat it. So this is Dr. Frost's conceptual model of how hoarders get to be hoarders. It starts with personal or family vulnerabilities, early life experiences, and we all know that cognition is what creates feeling. We know that it can work both ways. You can sometimes get feelings that create how you think, but in general, it's how we think that creates our feelings. So this combination of personal and family vulnerabilities plus early experiences shape our thoughts and our beliefs. They create our emotional responses. And in people with hoarding disorder, they result in efforts to obtain pleasure through saving things and escape or avoidance of unpleasant emotions. Now, we know that most of us don't like unpleasant emotions, and we don't like to be upset most of the time. And so we avoid the things in general that can cause us to be upset. And most of us like to pursue happy thoughts or good thoughts. For these people, these personal vulnerabilities and early life experiences will lead to chasing the purchase of things, the collection of things, and the keeping of things, and avoid the distress that comes with trying to get rid of them or organize them. So, what are personal and family vulnerabilities? A family history of hoarding. So, immediate family, parents, siblings, grandparents. I would note here that many times we've talked to people with hoarding disorder and they deny having a history of it in their family. And what we find is one of two things. The general thing is they don't know their family. They're really not greatly familiar with their family tree, their family history. Or because they're so comfortable with their accumulation of goods and material that they don't see in their generational history that people have been hoarders. Clearly, comorbid mental health conditions can contribute to developing and maintaining hoarding disorder, specifically depression, anxiety disorders, obsessive compulsive disorders. So information processing deficits, perception of what things are. And what does this mean? Well, very often objects mean something more than what the object is to the person. For instance, a person might go to the store, purchase something, and in the process of purchasing something, they meet a cashier or a salesperson that they really like and enjoy. And then when they get home, that object reminds them of that person. So keeping the object, when they see or touch the object, it brings back the memory of that person. When it brings the memory back of the person, then they feel good. So to them, getting rid of the object would be like getting rid of that person, getting rid of that memory. And so that's why they have so much difficulty with that particular object. Attention. Most people that have hoarding disorder, there's a high incidence rate of ADHD, attention deficit disorder, attention hyperactive disorder. And so people will get a lot of distracted thinking and have a hard time staying focused on what they're trying to do. Memory is a problem. The interesting part about this is not that they have a poor memory. The issue is generally that they have the perception that their memory is poor. Based on this, they'll try and compensate for it. So whether their memory is actually bad or not doesn't make any difference. It's their belief that their memory is bad. So they have to keep things because they believe that if they get rid of it, they'll get rid of the memory. Categorization. So most of us aren't born with the ability to organize. We learn this over time. And we develop filing systems. And like anybody, when you have a filing system, you create individual folders. And then you name the folders, and then that's where you know how to go and find the things that you're looking for. The problem is if you get too many folders, or if you get too many categories, it becomes extremely hard to find things because you don't remember which categories you have, or if you have too many subcategories, you may not remember what folder you put the information in when you organized it. So and for somebody that worked with paper a good part of my career, when you get too many pieces of paper, there's almost no way to organize it. Decision making is another problem for people with hoarding disorder. I had one client in particular, she was a hoarder, and she articulated this very interestingly to me. She asked why she couldn't make decisions easily. She articulated that when she needed to make a big decision, she rarely had a problem with it. When her doctor found a lump in her breast, no problem. She immediately arranged for appointments with surgeons and the necessary people. She arranged the hospitalization and ended up being treated for it and had no problems through that whole process. But then when she talked about slips of paper and other pieces of minor stuff, she really struggled to make a decision. So big decisions were easy, small ones, not so easy. So every little item reminded her of something and spurred good memories for her. And so she kept them. So conceptual model. The early experiences for most people with hoarding disorder end up causing them to believe that they are unworthy, unlovable, and helpless. This became evident to me. One of the people that was referred to me was actually a couple. They lived in a nearby inner ring suburb in Cleveland, and they'd been together quite a few years. When I went to see them, their house was clearly hoarded. They were a very interesting couple. They clearly loved and cared for each other, but it wasn't evident. The husband was a city official and worked for the city, so he was extremely concerned about it. And he spent a lot of time blaming his wife for it. Indeed, in the conversation, I discovered that they also had they used to own a business, and it was located about 3 or 4 miles away. And though I did not enter or see the business, the husband indicated that it was completely hoarded as well. When I sat at their dining room table, they had cleared enough area away from me to be able to come in and sit and talk to them. When I articulated this to the wife, she immediately said, "That's exactly how I feel." Unfortunately, her husband couldn't hear that. In spite of the fact that she was saying she felt unworthy, unlovable, and helpless, he was more interested in order and rules and seeing to it that she would not collect things. So it was a very difficult situation, and indeed they ended up not seeking treatment and closed out their case, and so I was never able to follow up with them. But just unfortunate and sad. Very nice people. So personality traits. The first one there took me a long while to figure out. One would think that perfectionism wouldn't be apparent in a hoarded situation. But I understand perfectionism. Perfectionism often leads to procrastination. And being a semi-procrastinator myself, I can understand this. When you have something and you want to do something correctly with it, it takes some time, particularly when you think about organizing paperwork or organizing other things. And the more items you have, the more difficult it becomes. So if you want to organize them correctly, it takes time. If you don't feel like you have the time, or if the task of trying to organize it seems overwhelming, hey, we do it tomorrow. So perfectionism leads to procrastination on occasion, and makes it very hard for people to organize stuff. So perfectionism is a high mark of people with hoarding disorder. Dependency doesn't seem that way because they become more and more isolated over time, but they are usually dependent on 1 or 2 friends, and they're dependent on the way other people think about them. One of the clients we had referred to us, and since we only work with the aged, we often found many of these people were disabled. And this gentleman in particular was very disabled. He was barely able to walk, but he had friends, and the friends had cars, and they were mobile and able. And so what they do is they put him in the back seat of their car, and he had memorized every garbage pickup day in the city of Cleveland. So basically what they do is put him in the car, and he'd drive around, tell them what streets to go to. And as they'd cruise the streets, he'd say, "Oh, stop, look at that." And they'd go out and examine stuff that was on the tree lawn ready for pickup. And then for the items he wanted, they'd go in his trunk and he'd bring them back home. I had one client who lived in an inner ring suburb, and even though he was highly educated, had a PhD, he was into bikes. He thought they were good exercise, and so he got into the habit of repairing them. So his apartment was just jammed full of bikes and bike parts. But he'd do the same thing. He'd go out and troll the streets and collect bike parts and buy parts of them. And unfortunately, most of them were not usable. And when you talk about waste, he would specifically collect them so that he could fix the bikes and give them to somebody else. Though once they got into his possession, they ended up being partially fixed, hanging around in his apartment and never going to anybody else. So they ended up being completely wasted. Anxiety sensitivity is another hallmark feature. So these are people that are sensitive in ways that many of our other people are not. This comes to play when you're working with people who hoard. Criticizing them doesn't help because they've heard it all. They've been listening to it for years because their original family gave them grief about this. And they didn't deal with it then. They're not about to deal with it today if they can help it. So they'll avoid it. But they'll be very sensitive about it. And saying the wrong thing can easily get you out of the case. There's also some level of paranoia. It's often, one of the things I learned right away with people who hoard is not to talk about their possessions. One of the things that happens is they end up wanting to give you things. So they'll give you whatever you look or admire. And these are things you don't want to do because you don't want to take anything from, particularly if you don't know what the quality of the inside is. The last thing you want to do is take any of their possessions. The paranoia comes when if you do take them, then their belief is every time you come in, they're looking to steal things. So in particular, we used to work in teams at Benjamin Rose, and we had home health aides that would go in and help with people. One of the things we learned is that in many cases, particularly when there's some level of paranoia, you don't want to take possessions into a house. Briefcases, bags, and those kinds of things, they will believe that you actually took their possessions when you leave their house. So generally with people suffering from paranoia and hoarding disorder, we would not end up taking things into their houses because of that issue. So the conceptual model is the family and personal vulnerabilities combined with information processing deficits leads to emotional attachments for the possession and equals behavioral avoidance. Putting things in a pile in the middle of a room allows the person not to deal with it. One of the cases we had was a young lady who lived in a condominium that she owned, was extremely hoarded and had spilled over into her furnace room, which actually was out in the hallway and down. And because it was paper products, posed a fire risk. Her daughter was kind enough and paid for organizers to help come and clean out her place. And then she eventually moved to an assisted living facility. When I looked at the condition of her condo, and then she moved to this place, that was after I had been a director. So her case was assigned to to one of my workers. When she moved, I went to visit her at the new place. She was having some difficulty relating to her worker at that point in time. And the difference between the condo and her new place was unbelievable. The place was clean, neat, and orderly, uncluttered. with the exception of her kitchen table. She had a fairly large round kitchen table. And of course, it was piled with items and paperwork and other kinds of things. And right next to it, the organizer and her daughter had bought her a filing cabinet. It was a gorgeous filing cabinet, 2-door, with solid oak. So I got permission and went over and looked at the filing cabinet. Of course, when I opened it, completely empty. On top of her table, of course, were numerous bills, including utility bills and stuff. And so I asked her, well, how about if we just create a file folder and put these utility bills in the file folder in the filing cabinet, and that way you'll be able to find them. And of course, she went off the deep end. Oh no, if I put them in that filing cabinet, I'll never be able to find them. Completely oblivious to the fact that there was so much stuff on her kitchen table that she generally couldn't find her bills and was often behind in payment of her bills. So amazing that these people can have such odd beliefs and thoughts about their items, about the behavioral stuff, and still not be able to organize it. Animal hoarding. So the primary person who's created a similar model of hoarding disorder is Dr. Gary Prevalence. He used to be with Tufts University, and he's retired now, but he came and spoke for the hoarding task force even after he was retired. One of the things that he helped us understand is that the number of animals doesn't indicate a hoarding situation. It certainly can after a while, because when you have too many animals, being able to care for them, get them veterinary care, becomes cost prohibitive. As a matter of fact, one of the cases that that I became aware of was one in a neighboring county, about 2 hours south of Cleveland. Was a mother-daughter team that started out as dog breeders. And so they were making a living in part by breeding specific dog animals, dog breeds. And when we got information on them, they were up to 100. They had 100 dogs. And of course, with 100 dogs, just trying to get them veterinary care, making sure they have all their shots and are treated properly, is almost impossible and becomes cost prohibitive. The issue is not the number of animals, it's the way the animals are kept. It's what they fail to do for the animals and their failure to recognize the animals' needs. So this is Dr. Petronek's model of how animal hoarders become animal hoarders. They're really people who love and care for animals a great deal. They usually start out as rescuers and become unaware or infected with denial about the condition of the animals. They have difficulty with the understanding the animal's needs. One gentleman that was referred and I saw for a while, and I'll tell you the story of how I got him, I think, to stop hoarding animals. He was referred to us by our Adult Protective Services system. He lived in Cleveland, near the border of another inner ring suburb. And he had, at one point in time, 30, 35 cats and they had cleaned out the cats, taken all of them out of his place. And then they actually connected him with some agencies, and they helped him spend almost $60,000 to get the house rehabbed. He was never married, lived with his mother. They became aware of it when she got sick and ended up passing away. But the roof had leaked. There was damage to the structure, so they helped him get a grant to get his roof replaced. There was so much fecal matter in the house that they basically had to come in and redo it. They took the drywall off the walls, put new drywall in, sealed it. They had basically rehabbed the house. Told him he should never ever collect animals again, and then left, and everybody went away. 2 years later, when we got the referral on him, he was back up to about 30 cats. And animal control actually made actually I misspoke. It wasn't Adult Protective Services, it was animal control who made the referral to us. And they were in the process of taking the cats away. So I intervened and actually encouraged them to let him have a couple of cats. They were baffled by that, but I pointed out that, again, if you take all of the animals away from him, it's going to leave a void in him so big that he's going to end up collecting more cats. And indeed, he tried. His big thing was he started out leaving cat food out by his garage. And then, of course, with the winter weather that would come, it moved to the front porch of his house. So they would just have to reach out and put some food and water out on his porch for the cats. And then, of course, in the process of feeding them, he'd bring one or two in. I think the resolution came, he not only loved cats, he loved most animals. So one of the things I pointed out to him was there were two articles that talked about, one was about cats and one was about birds. When cats are feral, you end up with a dominant male that will have a turf, usually of several blocks. And he's the boss of that area. And the cats that come in, he decides who comes in, who stays, and who goes out. He ends up being he's a tomcat. So other males, large males who come into his territory, he'll end up fighting with them. And then when he becomes dominant, they'll leave. They'll have to go someplace else. So when you get rid of the dominant male cat, take them in, all it does is invite more cats into a specific neighborhood because another cat will seek to replace him in the dominance. The second article I gave him was about how cats kill birds. They're the largest predator of birds, and they, we've lost millions of birds over time. I guess if you don't care about birds, it's no big thing, but he did. And so when I helped him understand about how cat society works and how they prey on birds, it bothered him. And at least at the time that I retired, my belief is he was still down to having only 2 cats in his house. But the big thing is, because they really can't understand the animal's needs, physical problems for the animals, whether it's birds or cats or whatever they have, they really can't see them, and they'll just not be able to recognize it, and the animals will be suffering. So this is the next slide in the next photo. This occurred in an adjoining suburb to Cleveland. It's called affectionately the birdhouse. The building manager of that city and 5 of his first responders found this house and went into it and helped him clean it out. The individual had 30 birds. The building manager himself got sick with a lung infection, missed 6 months of work. And he told me his physician told him that if he got another lung infection like that one, that somebody else would raise his children. Every one of his first responders developed some kind of lung or respiratory illness from being in this house. So birds are the worst. The reason that birds are the worst basically is if you don't take care of their cages, their droppings have airborne germ particles in them, and they present a breathing risk to anybody who's in that environment. Now, that doesn't mean that you're going to go into a given house that has birds in it and be in it for 5 minutes and get sick. You're clearly going to have to be exposed longer than that. But the droppings of the birds provide a health hazard that's even worse than the droppings from dogs or cats. This is another photo. That same building manager from that city had given me quite a few, several hundred photos they had taken. And this is one of them, and I usually use it in my presentations. And the reason it I use this photo is it reminds me of an incident we had. We had one client who was referred to us, was actually the mother. She was a 92-year-old living with her 60-year-old son. He had worked for many years until he became disabled. He had worked for one of the steel companies. So he made lots of good money, and with it was able to spend a lot of it. He belonged to the Book a Month Club. So when I walked in to their house, it was a relatively small house, 2-story. But when I walked in, the books were piled higher than my shoulders, and there was only a narrow pathway to walk in. So we were concerned, of course, for the mother, because at 92, a fall or any kind of problem would make it difficult. You couldn't even get a gurney in there to get an ambulance. If she had a major problem and needed to be hospitalized, you couldn't even get her out of the house. You were at risk just walking in it. So we convinced him, for the sake of his mother, to get the lower part of the house cleaned out. Not the whole thing, but just the entrance area, the kitchen, and the lower part of the house that were functional. He agreed. We found a handyman, and he paid him $600. A guy came on a Wednesday and helped them. They took 12 to 15 truckloads of stuff out of the house. So that was on a Wednesday. Thursday morning when I got into the office, I get a phone call, and it's him on the phone, and he's complaining about the fact that they took all of his stuff. And I said, so, I'm confused. Didn't you pay them to take the stuff away? And he says, yes, but not the good stuff. And when I asked him to clarify what good stuff was, he told me that he talked about his stamp collection. Well, I had seen he had a stamp and a coin collection. The coin collection was actually not real coins. They were from a provider that had unique coins that would come in plastic boxes, containers. Most of them were broken, not well cared for. You know, they were essentially worthless, as well as the stamp collection. It was not organized. It was in total disarray. So that didn't bother me too much. But then he said, and then my bonds. And I clarified, you mean US savings bonds? And he said, yes. So I called the handyman back up, and fortunately, the dump was closed on Wednesday. And so he took all the stuff, and I asked him where it was. He put it in his personal garage. I explained the situation, and he went through it. Friday morning, when I was at work in the morning, I got a call from the handyman, and he found $18,000 in US savings bonds. So, you know, when you look at this and it looks like junk, the problem is it may not be junk. There clearly can be valuable stuff in and among the stuff, the belongings, and particularly if you have years and years of dust and dirt accumulation, you know, they can look terrible. The fact that the stuff looks terrible doesn't mean that there's not necessarily valuable stuff in it. So if you happen to be a community provider and you're going into these facilities, you have to be aware, A, of your personal safety to make sure that you stay healthy, and you know, wear protective environment, protective gear, gloves, boots, whatever you need for ones where there's a lot of accumulation, particularly from animals. You want to make sure that proper authorities that have proper gear are involved so that they can protect themselves and protect you. So how do you assess it? We'll see if my, one of the things that Dr. Frost developed was a clutter image rating scale. This makes it very easy because it's not super involved. I'm going to hope my link works, and I'm going to take you to his rating scale. And it worked. So the rating scale, which is, you can find it in several places, including on the Hoarding Connection website, which the link is on the first page of this presentation. And the presentation will be sent to everybody at the end of the session. As you can see, they used a 9-point scale here. So we have picture number 1 is what we would consider a normal environment. And then you increase the clutter up to level 9. So the break point is somewhere between pictures 4 and 5. When you're at levels 4 and 5, you really need to consider that this is beyond what an organizer can do. This is where you need to believe that you're looking at referral for competent mental health care. So the scale has 3 rooms: your living room, kitchen, and bedroom. At 5 or more on that rating scale, and the rating scale is in the public domain, you can just download it and keep it. Though you can't charge money for using it. But anything over a 5 needs mental health treatment. So when we come to treatment, as I said in the beginning of this, we're looking at 2 types. The first one is management, not treatment. Management means engaging the person, seeking to form a relationship with them. My experience with people with severe hoarding disorder are pretty engageable. They often seem to have skills. Um, they just don't look like your traditional severely mentally ill people. So let me give you another story. When I first started at Benjamin Rose, we actually used to do groups, and we would bring maybe 10 or 12 seniors in, and they were essentially social groups. They were clearly designed with a treatment eye in at the end to help them function better in the community. In one of the groups, we had a young lady who became like a mother hen. She was about barely 5 foot in height at best. But she was very social. She was a real sweet lady. And she became like a mother hen. She took over, we would provide refreshments. So she would set tables, put napkins out, just tend to everybody, all the other seniors in the group. She later became referred to me as a client, and I ended up seeing her. The first time I got to see her home, she lived on the near west side of Cleveland. She lived in a 2-story brick ranch, or not a ranch, but a 2-story brick home. And from the outside, it looked fine. When I walked in, I could not believe it. It looked like somebody had thrown several hand grenades in that just exploded. The place, the contrast was she'd come to these meetings. She was always nicely dressed. She was, hair was done. She often had makeup on. She just looked, on the street, you would never be able to meet her, speak with her, and believe that the inside of her living arrangements could look like they did. They were truly terrible. She didn't have Sologomania, but I can tell you the place was not clean. It's important that you respect their belongings and them as a person. Your nonverbal behavior is as important as your verbal behavior. If you look around and look horrified, she's going to react to it, she or he. By the way, my understanding is from the research that's been done, hoarding disorder is an equal opportunity annoyer. It affects males as well as females. The original studies tended to look at more males than females. Later studies said more females than males. From my understanding, current studies, it's equally divided in the population. So engagement, dues. You really need to clarify your role, whatever your role is, whether it's a social worker, mental health worker, adult protective service worker. Letting these people know what you do and what your intention is very important. Letting them know that you're there to help helps. And listening is very, very important. Now, on the other hand, you don't want to listen too much. And I'll tell you why. Many of these people are excellent at relating stories. Many of them have very diverse backgrounds and are, and many of them often have been in influential places and know influential people. And so they can relate a lot of stories. The problem is if you start them talking, you have to keep them focused. If you don't keep them focused on the task at hand, your one story will lead to another story, and you'll never get anything done. So listening is important, but being able to focus and keep the person on task is extremely important. Seeking to form a relationship is important. Now, I believe most of these people, it's relatively easy to form a relationship with them. They are generally likable people, and they're relatively easy to engage. But typical with most relationships, both your nonverbal behavior and your communication needs to be appropriate. Criticizing, mocking, or belittling either the person or their belongings just doesn't help. It will put them off, make you be the enemy, and that's not going to achieve anything, and you're not going to have any potential for progress. You can't judge the person or their belongings, and you certainly can't try to work the situation alone. This is one of the few mental health disorders that really requires a team approach. You have to have multiple people involved, including city building inspectors, management people, because if you don't, senior workers. One of the things I didn't talk about that I missed in the development of hoarding disorder usually starts between the ages of about 15 and 25. Randy Frost indicated he's seen it in children as young as 3 who were referred to him for treatment. That's unusual, but somewhere between 15 and 25 is when the basics of the problem occur. In the 30s, the 20s and the 30s, particularly the early 30s, it's generally not an impairment problem. But what we know is that each decade that goes by, it gets worse and worse. The other thing that happens is there are often triggers. A death of a parent, a sibling, any kind of loved one will often accelerate and make the situation go worse. One of the couples that was referred to me from an inner ring suburb that I went out to see and got a lot of good information on. Apparently she was the hoarder. The husband was co-opted. They had done well, reasonably well, most of their life. And in the late 50s, one of her key relatives died. And that seemed to be the trigger that really started the ball rolling. And from then on, they were in their 70s, late 70s, when they were referred to us. By that time, from her late 50s and into the 70s, it really got bad. So traumas and deaths of key people in their lives can accelerate and make the situations worse. So this is not a problem you can solve alone. There are no quick solutions. Let me say this once, and please everybody hear it. Cleanouts do not work. A cleanout, and I realize in many situations, particularly in some cities, because of zoning codes and building codes and hazards, fire hazards in particular, sometimes cleanouts are necessary for the health and safety of the individual as well as others. Sometimes they're necessary, but a cleanout is a Band-Aid, doesn't solve the basic problem. And what will happen is when you take away the belongings, you're going to accelerate the feelings inside that person, and they're just going to go out and accumulate even more unless they get treatment and therapy. So cleanouts do not work. Like we found out with the gentleman with the $1,800 in US savings bonds. Cleanouts don't work. Threatening or exaggerating consequences. One of the things we learned early on is don't tell people things are going to happen if they're not going to happen. We know that many municipalities vary in their ability and their desire, to enforce certain zoning regulations and rules. In some cities, they just don't have the wherewithal to enforce them. And when referrals are made to cities and they do inspections, very often not much will happen. In other instances, the building people will jump on it quite quickly and will go and do clean outs and that kind of stuff. So the enforcement varies a great deal. If you're in a city where they do rigid enforcements and get busy and take things away quickly, you don't want to tell them that much will not happen. If you're in a city where not much will happen, you don't want to tell them that something's going to happen, because if it's not going to happen, it's just like raising children. Found out from raising my kids a long time ago, if you say no and don't mean no, they'll learn that no means maybe or yes. So you don't want to threaten or exaggerate any kind of consequences. So for management, we want to do mental health treatment. Treatment varies from state to state. Usually there's some kind of overarching authority for it. Most states have either a health department or a mental health department, and then often county by county. So if you're a non-provider, you want to find somebody that can provide treatment and refer them. You can refer people for treatment. Of course, if they don't want treatment, there's not much you can do about it. But states do have zoning laws and can prohibit people from keeping particularly the exterior of their property in unsafe and unsanitary conditions. For most people with insurance, they can usually get a mental health provider. Almost all insurance policies now have provisions for mental health providers. Although my understanding is that the time lag between when something is, a theory is developed in academia and colleges, that it takes 20 years for it to get out into the community and into regular private practice. Since Dr. Frost's first manual on the treatment of hoarding disorder, and I have it right here, wonderful manual, and it's included in the references. It came out in 2007, I believe. So from his first study in 1992, and here we are, 2020, and we're still quite a ways behind. Many providers do not really know how to do individual therapy or group therapy, but they're required to do it. So you need to help them provide a provider. And if your local mental health agency doesn't have people that are qualified in this, they need to be pushed. You need to advocate that they find people who can do it. Clearly, individuals who have Medicare and Medicaid, any provider who provides services to them will be able to take it. Ethical considerations. So the question is about reporting safety hazards. When you find a hazard like this, they need to be reported to the Board of Health. In most states, 60 years is the break point for referrals to Adult Protective Services. So there are some caveats. One of the problems with reporting people particularly if they live in apartments. The homelessness is not a solution to hoarding disorder. So reporting somebody and having them end up being evicted from their apartment doesn't solve the problem. You're going to take that person and put them on the streets. Here in Cleveland, that's not a great place to be given our winter temperatures and the snow. So this is not a solution. Getting them real treatment is important. My experience has been with most hoarders is that because they're relatively normal in their cognitive abilities, they're very concerned about enforcement. So they respond quite well to police, building people. There's always exceptions to the rules, but in general they do. And so they may enter treatment not because they're willing, but because they're being forced to. But my experience is also that most people, even if they're forced to, if they go to therapy and get some treatment, they'll benefit from it. So on your screen now is an ethical consideration grid that was developed by Maria Schreimer in Georgia Annisberger. Maria's an attorney, and Georgia Annisberger is a social worker, and they developed this grid as a way to help make and to conceptualize what they call the gray zone. So if you look in the upper left-hand corner, you see competent and fully capacitated. Hopefully that's you and me. In the lower left corner is incompetent but capacitated. So this is a person who is physically able, can walk around, can talk and everything, but may have dementia or some other kind of issue that makes them not mentally competent. In the upper right-hand corner is somebody who's competent but incapacitated. So this would be somebody who may have a debilitating physical illness, confines them to a wheelchair or makes them bedbound, but mentally they're fully intact. In the lower right-hand corner is a person who's incompetent and fully incapacitated. So these are the people that you see in nursing homes, confined to wheelchairs, bedbound, who not only can't physically do anything, but who are also demented to the point where they don't know what's going on. So the problem is not in any of the corners. Any of the corners, they're easily recognizable. The problem is when you're transitioning from one corner to another. So if you're going from competent and fully capacitated to incompetent or incapacitated, or to incompetent, these are the areas right in here where they become problematic, because people have memory loss, people are starting to get dementia. They may look and act like they're competent, but they may have portions and periods where they're not really able to make solid decisions. When they haven't deteriorated to the point that they're clearly incompetent, it often becomes hard to determine what's going on and what to do about it. So the Hoarding Task Force of Cuyahoga County, early on, one of the things that we did was bring in speakers from Orange County, California. This was in early on in the development of the Hoarding Task Force. So probably had to be about 2009, 2010. I don't know the exact date, but they had already developed what they called the enforced harm reduction model. And they came out and did a presentation, and they allowed us to adopt their model. So these are the goals of the model, of course, to ensure that all the property complies with acceptable community standards, that people suffering from this disorder are treated properly, to keep first responders safe, and to provide support to those who intervene. Again, it takes a team. Hoarding is such a complex problem that no one person can fix it. So one of the big things is that for cities and communities, they need clear and well-written housing codes and regulations. They need everybody on their teams, their inspectors, to be aware of what those regulations are and willing to enforce them. What doesn't work is silos. You can't act in your own little bubble and expect to be successful with hoarding. It's just not going to work. So who would be on a team? Of course, hopefully the individual has been engaged, and the individual who's suffering from hoarding disorder would be part of this. You have to have housing inspectors and willing to enforce the codes. Again, varies from community to community. I've worked with some communities that go overboard with this. I've worked with many communities that lose the will and the determination to persist. Often communities recognize that their constituents vote, pay taxes, and so they're very concerned about offending them. And so they will override some of the decisions from the inspectors. I'm not trying to get into politics here. I'm just saying that they need to be, everybody needs to be on the same page. Housing courts. Many courts now use mental health courts, and this is very important because they have much better understandings of mental health diagnoses and mental health agencies and mental health problems. You're more likely to get a good outcome when the housing court is aware of and understands mental illness and mental health issues. Every time I had a case like this that was before the courts, I always involved legal aid. It's important to protect their legal rights. Just because they're mentally ill doesn't mean that they're not entitled to the same protections that the rest of us are. So getting together a complete team is one of the first steps to getting resolution to hoarding disorder. You also need a mental health professional, particularly one who has skills or knowledge of hoarding disorder. If the person's over 60, you might need to involve adult protective services. And of course, that varies from state to state in terms of ages and how well they work. Understanding that it is a process, and the process takes time. Again, there are no quick solutions. Excuse me. There are no quick solutions, and cleanouts don't work, so it takes time to get this done. As a matter of fact, it reminds me of one case that our adult protective service people talked about. They had a couple referred to them, a house that was hoarded. They got involved and started working on getting the place cleaned up. The couple ended up just abandoning the house. They left. They found that couple later in another house that was already in the process of being hoarded. And when they got to work and did a little history, they found out that they had 5 or 6 homes like that. They had purchased them, hoarded them, and then defaulted on them, just walked away and left the houses. And so they had 6 or 7 of them just abandoned. Again, real consequences. If nothing's going to happen, don't exaggerate them. Being prepared, it's important for all parties, including housing courts and building inspectors, to know what services are out there in their community to become involved, to make referrals, and to help these people. If you don't want to be successful, then not knowing what's out there is the first step. You're going to have to know what's available. And advocacy. You have to push, particularly your mental health providers, to become involved. So what doesn't work? Intervening alone. No man is an island. You can't do this alone. We need a team approach. Again, one-time cleanouts will not solve the problem, not ever. All they do is make things worse. We do a cleanout, we make ourselves look and feel better because the place is acceptable to us. In the meantime, the person who experienced the cleanout, their anxiety is against the ceiling. So we've been over most of this before. So treatment. There are no known medications that work on hoarding disorder. There are medications that are used. Several of the antidepressants, particularly the new wave ones, SSRIs, selective serotonin reuptake inhibitors, have been used, and the outcome has been kind of mixed. They certainly help with the comorbid symptoms, particularly anxiety and depression. And often they allow the people to get motivated and to engage in treatment better, so that you have a higher degree of success. But in and of themselves, they won't work. There is no miracle pill. There is no one treatment that's going to work with this. And it just takes talk therapy and or medication treatment if it's called for. So the primary treatment for hoarding disorder is cognitive behavioral therapy, or a modified form of it. Dr. Catherine Ayers uses CREST. It's basically a combination of cognitive behavioral therapy and exposure therapy. Exposure therapy is a method where a person articulates a fear, and you begin to gradually work them towards actually facing the fear directly, in the belief that once they experience the fear and then survive it, that'll be the beginning of the resolution of their problem. She's been very effective with that, and so her therapy has been widely used and replicated, and seems to be very effective. Another form of effective therapy is buried in treasures, which is a peer group intervention that was created and designed by Dr. Frost and Dr. Steketee. The manual is in public domain, I believe. You can download it off the internet. And we started Buried in Treasures groups through the Hoarding Task Force and through Benjamin Rose a number of years ago. We've got a small core of dedicated individuals who lead our treatment groups. We try and run 4 a year. Cuyahoga County is physically a large county, so we try and run 2 groups on each side of the county. We're divided by the Cuyahoga River, which splits Cuyahoga County and Cleveland. So we run 2 groups on the east side and 2 groups on the west side. Our success rate has been mixed, obviously. For some of our groups, we've had as few as 3 or 4 people in them. In others, we often run 8 to 10 people. And they're 15-week sessions. And the research on them clearly shows that they have a pretty good effect. As a matter of fact, the effect in 15 weeks is almost as good as individual therapy, which takes 26 weeks. The both types of therapy are Dr. Frost 26 weeks is articulated in his book, which is listed in the references, and Buried in Treasures is also listed there. And we've had a lot of success with them. I don't know the total number of groups that we've run already, but there's quite a few people that have gone through the Buried in Treasures treatment groups and have done quite well. Some of the clients that I've seen, I've had the good fortune to have seen before and after because of our work with them. And some of the clients that I've seen their places after treatment are really stark and quite different. To be able to go into a house that's so hoarded that you can barely walk through a room, can't see floors or carpet, and then to go into that home afterwards and to see open areas, the actual carpets and the floors and what colors they were is gratifying, and it's just wonderful to see. So that essentially concludes the presentation. I assume there are questions, and I'd be willing to take them.
Okay.
Okay.
Yeah, you had a few comments in the chat box. I'll start with the most recent.
Okay.
So Kent asked, how are you handling the BIT groups during COVID?
We are not doing currently, we are not doing Buried in Treasures groups, except virtually. For those participants that have computers or smartphones, you can still do a modified Buried in Treasures group. The problem, of course, is that Buried in Treasures, along with individual therapy, requires the completion of forms. There's no good way using virtual methods to make sure that people have completed homework assignments, filled out the forms, and that the leaders can get the information back, or that you can see them for good discussion. So virtual groups are still possible, but they're really not a substitute for in-person contacts. we're thrilled that the vaccines are finally developed, and hopefully that as people begin to get vaccinated, that they will take advantage of the serum, and this illness will disappear off the face of our country.
Okay. All right, so Dean has put the facilitator's guide link into the chat box. Also, Gina Mack says that they have berries and treasure workshops in Nebraska as well. You had another question from Larry. Do you have any examples of what happened after a non-voluntary clean out occurred of a former client's home?
Well, the one I just cited a few minutes ago, where the people hoarded and abandoned a home and then went on to hoard and abandon several other homes, is a clear example of what happens when you do a clean out and it's non-voluntary. We've also had other people, I personally have dealt with people who, in particular, they hoarded not only stuff inside their house, but accumulated a great deal of clutter in the yards. Inspectors would come by and cite them, and they'd end up having to go to court for it. Many of those, the city would come and remove the belongings. It would not take long, probably several months, and the yard would generally be in the same kind of condition as it was before. Suicide is always a risk. We've been fortunate. We have not had a high suicide rate in my experience with people who have hoarding disorder. I don't know if that answers the question or not.
Okay. Michelle asks, she says, what is the percentage of individuals who will seek treatment on their own? I am thinking most are not willing or struggle with dementia.
I would not, the number of people we have with hoarding disorder that have ended up with dementia are very minor. And usually their situations are handled well before that. Engaging people, again, as I said, most times people will understand and will seek treatment when and if there's an outside threat. However, people will often and will call in seeking treatment on their own. I'd say before about 2007 or 2008, I never had a person call me up and say, I have a hoarding problem, I want help. However, I've done many of these presentations. I used to go around to senior centers, and I've had several people approach me in those presentations asking for the ability to be referred because they had a hoarding problem.
Okay. Ashley, she asks, how can you engage an individual into treatment or therapy, as I know that can be needed? If it reaches the level, she said, as she knows, that's needed if it reaches the level of condemning the home and or the home has to be cleaned in order for the person to return to the home.
Yes, this is a problem. You know, we've had several of those instances. One occurred on the street in the home that I lived in prior to this one. On the very same street, a mother-daughter team were discovered. That community was fairly aggressive about how they handled cleanouts. When they discovered the house, they forced the mother and the daughter out of the home, put yellow tape around it, and the mother had to go living in The daughter was the hoarder. The mother had to go live in a hotel or a motel for a couple of weeks. And they did a forced clean out. They took out most of the stuff in the home. You know, I was not happy with that instance because, first of all, they'd been living in the house, as hoarded as it was, they'd been living in the house for years. So even though we see it as a hazard to them, it's clearly a hazard and a fire hazard, if nothing else, but they'd already been there for years. Forcing the mother and the daughter out of the house while they cleaned it out was a financial imposition. I don't know the details of it because they never became our clients, but it meant that the mother, who was elderly herself, was forced to expend a fair amount of money to live outside of a home that she owned in. And it was distressful to her and her daughter to be out of the house. And of course, I have no idea of what happened when they went back into it, but I do know the daughter, who was the hoarder, would have not received treatment and would have started again re-hoarding.
Okay.
Okay.
That was the last comment and question.
Oh, okay. Well, thank you for your time and attention for everybody. You can, if you still have continuing questions, you can go to the Hoarding Task Force, or you can send them to Regina, and she'll forward them on to me. Any other remaining questions? No.
The iPhone, did you want to say something?
Yes, can you hear me?
Yeah, what's your name?
April Emebo.
Last name April? Pardon me?
Emebo, E-M-E-B-O.
Okay, thank you. You can go ahead.
Nothing really. I just know that I've been running into that more and more when I do my home visits to set up services. I'm with the options program, and it's just very common.
Yes, you're here in Cuyahoga County?
Yes.
Yes.
It's very common.
Yes, it is very common. And do you report them when you see them?
Well, actually, a lot of times they come to us because they want us to help them clean up. We have a chore service. We get them over the phone, and so we have chore services that can help them kind of organize. But I have referred several people to Benjamin Rose already.
Mm-hmm.
So
yes.
it's just very common. I see a lot of animals, cats mainly. Yeah, it's a real problem.
Yes, for the safety of your workers as well as to the individual. You know, I have an advanced degree, and it took me a long time to learn this kind of stuff and to be involved with it. For the chore service people, who are usually poorly paid, undereducated, and are sent into these situations, this has got to be very, very difficult for them.
Yes, it is.
They really need a lot of recognition and a lot of support for the work that they do. It's hard to do this kind of work and get recognized for it. There are, well, again, the Beyond Overwhelmed study that I referred to earlier about San Francisco, the amount of, they also found about 4%, so 4 to 5% of the entire population suffers from hoarding disorder. That's an enormous amount of people.
Yes, it is.
Mm-hmm.
So the person on the iPad who's asking the SSRI question, what's your name? So someone says, how long does it take an SSRI med to work?
Generally they say 10 to 14 days at a minimum before you begin to feel, and as a matter of fact, the most dangerous point in time is somewhere around the 10th day, 10 to 12 days, because that's when you'll begin to get more energy. One of the things that depression does to you is it sucks all your energy. It takes away your motivation to do anything. The SSRIs, when you begin to take them, will begin to have an effect, and you'll start to get your energy and your motivation back. But before you feel really good in about 14 days, there is a risk, the risk for suicide goes up because you'll end up with energy, but bad feelings. When you think about depression, depression takes you down into a pit, and as you're beginning to come up, when you're halfway up that hill is the most dangerous time. Compliance with medication is extremely important. So with antidepressant medications, making sure you take the medication on time and when it's prescribed for you is very, very important.
You have another question. Do you have many enabling family members, and how do you work with them?
Yeah, families are as much of a problem as they are a help. Mostly because they've known the person who hoards for all of their life. They usually have very little patience with them. And what they try and do is hurry the situation along. And again, it's a slow process. You're talking about attitudes that get hardened over a lifetime. So these personal vulnerabilities and family vulnerabilities that started in early adulthood have been hardened over 40, 50, 60, 70 years. And so they're pretty ingrained. You're not going to fix them overnight. And it just takes a lot of time. Family members clearly and justifiably get impatient. It's hard not to. So even when you give them information about how the problem develops and what the steps are to fix it, it's just hard for them to bear with it. So yes, we've worked with a number of family members, and sometimes they're extremely helpful, and very often they're not helpful at all.
Your last comment or question was, what is the correlation between early childhood trauma and hoarding?
Again, trauma manifests itself in many ways. Trauma can be something as clear-cut as physical and psychological abuse to something as subtle as the loss of a loved one. So there's all different kind of trauma. Being bullied in school, there's just all kinds of trauma, and depending on the person's vulnerabilities, we talked about that, memory issues, perception issues, anxiety, sensitivity, those things combined with the trauma kind of pave the way for where the person's going to go. Some people become depressed. Some people get addicted, looking to control their pain with alcohol or drugs. Other people become hoarders. But trauma plays a big part in it. And particularly with hoarding disorder, as I indicated in that one case, that couple in the inner ring suburb, where the death of a loved one really started the ball rolling and made things significantly worse. Trauma kind of shapes the response and adds to the degree and severity of difficulty.
Okay, I think that that's all the comments and questions, Bert. We at the ADAMHS board want to thank you for attending. I'm going to let Jean say something, and then I have if you got a couple of minutes, I have some last minute questions for the group.
I
Jean?
see. Okay.
Okay.
Oh, Bert, were you done? I'm sorry.
Oh, no, I'm fine. I'm done.
Okay.
Sorry, there's some construction going on right outside my door, so if that all of a sudden comes on, I apologize for the noise. Just wanted to thank Bert for sharing all that great information with us, and to thank all of our attendees for joining us today, and I hope you found today's presentation useful and informative.